In today's nursing mindset video, we're going to talk about a common tube you'll encounter in nursing, the nasogastric, or NG tube. Now, at first glance, inserting or removing an NG tube can just seem like a technical skill, but experienced nurses know that caring for a patient with an NG tube is really more about patient safety. The nursing mindset asks one question throughout the entire process. What can I do right now to reduce my patient's risk for complications? If you keep asking yourself that question before, during, and after every intervention, you'll naturally begin thinking like a nurse. Your nursing care begins before you ever touch the tube. Start by verifying the provider's orders and identify your patient using two patient identifiers. Then perform a focused assessment. Assess the patient's abdomen. Is it distended, firm, tender? Auscultate bowel sounds in all four quadrants. These findings become your baseline so you can later determine whether gastric decompression is improving the patient's condition. Next, assess the nose and mouth. Ask about previous nasal surgery, congestion, or a deviated septum. If one nostril has better airflow than the other, use that whenever possible. Inspect the skin around the nares for irritation or breakdown before applying tape or a securement device. This is especially important because NG tubes can remain in place for several days. Take a minute to prepare your patient as well. Explain that they'll likely feel a burning sensation in the nose and may gag briefly as the tube passes through the back of the throat. I also like establishing a simple hand signal before beginning. If the patient raises their hand, you know to pause immediately. Giving patients some control often helps reduce anxiety during the procedure. Let's talk about the actual insertion. We're going to start by positioning the patient in a high Fowler's position whenever possible. This promotes swallowing and helps reduce the risk of aspiration. You're going to measure the tube using the NEX plus 10 method. So for this, you're going to measure from the tip of the nose to the earlobe and then down to the xiphoid process and add an additional 10 centimeters. This helps ensure the distal opening of the tube is positioned appropriately within the stomach. Remember, however, that X-ray confirmation is still required before the tube is used, particularly before we insert anything into the tube. Lubricate the first few inches of the tube using water-soluble lubricant. This decreases friction during insertion and is much safer than petroleum-based lubricants if aspiration were to occur. As you begin inserting the tube, advance it gently toward the patient's ear, not upward. This follows the natural anatomy of the nasopharynx and reduces discomfort. Once the tube reaches the back of the throat, ask the patient to flex their chin towards their chest. This helps close the airway and directs the tube towards the esophagus. If appropriate, encourage the patient to take small sips of water and swallow while you advance the tube. Swallowing helps guide the tube into the stomach. Here's another clinical pearl. As you advance the tube, gently rotate it about 180 degrees. This small rotation often helps the tube navigate the natural curves of the upper gastrointestinal tract and decreases resistance. Now, speaking of resistance, never force an NG tube. If you encounter resistance, stop, reassess, ask the patient to swallow again, check for kinks, or slightly withdraw and redirect the tube. Likewise, if the patient develops persistent coughing, difficulty speaking, cyanosis, or a drop in oxygen saturation, stop immediately. These are warning signs that the tube may have entered the airway. Patient safety always comes before completing the procedure. Now, after insertion, let's talk about what happens with that. Once the tube is inserted, secure it carefully to prevent migration without creating excessive pressure on the nose. Remember, just because the tube is inserted does not mean it's safe to use. Like we noted earlier, initial placement should be confirmed by an X-ray before administering medications, enteral feedings, irrigation, or connecting the tube to suction. X-ray remains the gold standard for initial verification. If you're caring for a Salem sum tube, remember that it contains two separate lumens. The main lumen removes gastric contents, the blue pigtail is an air vent that prevents the tube from suctioning against the stomach lining. Never clamp the blue pigtail. Never connect the blue pigtail to suction. Never irrigate through the blue pigtail. Blocking the air vent prevents the tube from functioning properly and increases the risk of gastric mucosal injury. Let's talk about maintaining tube patency. Sometimes thick gastric secretions can slow or stop drainage. If irrigation is ordered, always verify tube placement first. Disconnect the suction tubing and irrigate the main lumen only using 30 milliliters of normal saline, instilling the solution slowly and gently. Never force the saline if resistance is encountered. If resistance persists, assess the tube for kinks and consider repositioning the patient onto their left side. Sometimes the tip of the tube rests against the stomach wall, and repositioning alone restores drainage. If you're caring for a saline sump tube, remember that the blue pigtail is never irrigated. After irrigating the main lumen, 10 millimeters of air may be instilled into the blue pigtail to help maintain the air vent and keep it patent. Continue assessing the patient throughout therapy. Keep the head of the bed elevated between 30 and 45 degrees whenever appropriate to reduce aspiration risk. Provide frequent oral and nasal care because the tube can dry the mucosa and become uncomfortable. Inspect the nares and surrounding skin at least every shift for redness, blistering, pressure injuries, or irrigation from adhesions. Another excellent habit is measuring and documenting the amount of tube remaining outside the patient's nose after placement has been confirmed. If that external length changes, the tube may have migrated and should be reassessed before it's used again. Let's talk about removal. So removing an NG tube is more than simply pulling it out. Here, ask yourself, has the patient's gastrointestinal tract recovered? Assess for the return of bowel function. Auscultate bowel sounds. Assess for decreased abdominal distension. If abdominal girth has been monitored, compare the current measurement with previous assessments. Ask the patient if they are passing flatus and whether nausea or vomiting has resolved. These assessments help determine whether gastric decompression is still needed. Once you've verified the provider's order, position the patient in high Fowler's position, turn off suction or discontinue enteral feedings, and disconnect the tubing. Then instill 20 milliliters of air into the lumen of the NG tube. This clears residual gastric secretions from the tubing and helps prevent gastric contents from entering the oral pharynx during removal, which will reduce the risk of aspiration. So when we remove, we're going to ask the patient to take a nice deep breath and hold it, or exhale slowly as you clamp or kink the tubing. Holding the breath helps close the glottis and protects the airway. Remove the tube in one smooth, continuous motion. After removal, make sure you inspect the tube to ensure it is completely intact. Provide oral and nasal care, reassess the abdomen, ask the patient whether nausea has returned, and continue monitoring bowel function as ordered. Remember, the procedure isn't complete until you've evaluated the patient's response. The nursing mindset isn't just about inserting, irrigating, or removing an NG tube. It's about understanding why every assessment, every intervention, and every reassessment matters. When you assess before acting, when you recognize subtle changes, when you stop because something doesn't look right, when you reassess after the procedure, you're protecting your patient. And that's what nursing is all about. That's the nursing mindset. Keep developing yours.